we need to think about secondary prevention. How are we going to stop the patient coming back into our care? How are we going to stop them having a relapse and a further infarction? Well, it's very important we tell these patients not to smoke. Patients that smoke are twice as likely to be dead in 5 years as patients that don't smoke. And we also need to advise patients to avoid smoky environments, because being in a smoky environment with secondhand smoke can also increase the risk of future cardiac mortality. So do whatever you can for them, give them some medication to wean them off the cigarettes, send them to smoking cessation classes, do whatever it takes, but stop these patients from smoking. Absolutely vital that we do that. Weight loss is very important. If patients are overweight, their prognosis will be improved if they can lose weight, especially losing weight off the tummy to reduce abdominal obesity is very important. And overall, a healthy diet is just a good thing. So a Mediterranean style diet is associated with an improved prognosis in secondary rehabilitation situations. Now, in our care, we probably want to mobilise these patients on the second day after an infarction, as long as there's no particular complications. And very often, especially if the patient's had effective reperfusional therapy, they can go home after 3 to 5 days if there's no complications. But it takes between 4 to 6 weeks to get an effective fibrous scar tissue healing of the infarcted area of myocardium. So we would normally say that these patients should be off work for at least 4 to 6 weeks to allow healing of that patch over the infarcted area of muscle. And because it takes that amount of time for the muscle to, well, the muscle doesn't heal, there's just this fibrous patch that stops the heart from leaking. It's not going to be contractile, but we need that for the stability of the heart. Because that takes 4 to 6 weeks, we'll normally restrict exercise for that period of time. But after that 4 to 6 weeks is up, it's very important that the patient does go on a progressive exercise program to increase their level of fitness, because fitter patients are less likely to reinfarct than unfit patients. And also we want to tell the patient about normal sexual activity. So again, after 4 to 6 weeks, we would normally say that the patient can return to their normal pattern of sexual activity, providing it's with familiar partners. We advise against having new partners if at all possible, because that's increased with greater tachycardia and hypertension than sex with familiar partners. But getting back to normal sexual activity, it should be mentioned, it is important, and that's part of the normal rehabilitation process. So exercise, rehabilitation, all these things, very important for secondary prevention. But then, of course, there's pharmacology involved in secondary prevention. There's drugs these patients are going to need that are going to improve their prognosis. And maybe the first one to mention is statins. All patients should be put on statins regardless of their cholesterol level. So obviously if the patient's dyslipidemic or hypercholesterolemic, we want statins to bring that down. But actually all patients should be on statins because we know this is improved or associated with an improved prognosis. And part of the reason for this may be that statins are anti-inflammatory. That reduces the inflammatory processes in the roof of the plaques. That can lead to plaque destabilization and renewed thrombus formation. So all patients should be on statins as long as they can tolerate them. And most people can. So statins for everyone. Also, as long as patients can tolerate it, they should be on aspirin for life, because the aspirin will reduce the platelet viscosity, the stickiness of the platelets, and that will make new thrombus formation again less likely. So aspirin for life, low dose, 75 milligrams a day, and most patients can tolerate that effectively. Now, patients will normally be on clopidogrel for the first 3 months, but patients that can't tolerate aspirin, we can think about using clopidogrel for them on a longer term basis. Beta blockers are associated with reduced mortality. And again, we know this from large epidemiological studies. So after an MI, patients should be on beta blockers, providing they can tolerate it in hemodynamic terms, providing the beta blocker is not lowering their blood pressure or causing too much of a bradycardia. Beta blockers are associated with increased survival, reduced mortality. Now, ACE inhibitors are very effective at preventing heart failure. So a lot of patients can go on to ACE inhibitors. And again, it's providing that it doesn't drop their blood pressure too much. So these need to be started gradually, titrated with the patient's blood pressure, because if we give them too much, they're just going to lose the blood pressure and they're going to fall over, they're going to faint, they're going to collapse. But ACE inhibitors definitely reduce the development of cardiac failure. Patients might need nitrates on an ongoing, when required basis for ongoing ischemia. We need to treat hypothyroidism if it's present. We certainly need to manage type 1 and type 2 diabetes effectively. That's absolutely crucial. And in fact, we need to manage any other comorbidities that the patient has, manage anything else the patient has, improve their overall level of health, and hopefully improve their overall prognosis as part of your secondary prevention management strategy.